People might wonder and ask me, are you the anti-cortisone doctor? It's a fair question. I don't like using cortisone injections for most conditions because of some well-known side effects. But does that mean I think cortisone is never useful? Of course not. There are some good uses for cortisone, but like any tool, it's important to understand when and how to use it properly. The first thing to remember is that cortisone is a relatively short-acting drug. When we inject cortisone into a painful joint, most of its effects will wear off in about 6 to 8 weeks. That's not very long. So if we're dealing with a chronic issue, something like arthritis or an injury like a rotator cuff tear, what we're really doing is putting a very short-term band-aid on the problem. It might temporarily reduce the pain, but it's not solving anything long-term. Now that wouldn't be so bad if cortisone were completely harmless, but we know it's not. Research shows that cortisone injections can weaken collagen structures, things like tendon, cartilage, and ligaments. Over time, repeated cortisone injections can contribute to the very deterioration that we're trying to avoid. This is why I tell my patients that we have to be very careful about how many cortisone shots we give, especially in weight-bearing joints, something like the knee or the shoulder, or around tendons that we rely on for movement and stability. So when does cortisone make sense? That being said, there are times when cortisone actually makes sense. In my practice, if I use cortisone, I usually have a clear goal in mind. It's not just about feeling better for a few weeks. It's about using that window of relief to create real, lasting benefit. So one common scenario is frozen shoulder. A frozen shoulder can be brutally painful. Like stretching even and physical therapy are the keys to recovery, but when someone is in excruciating pain, they often can't even do the exercises. That's where cortisone injection can actually be helpful. It reduces the pain and inflammation just enough for the patients to stretch and do their exercises with physical therapy. And here's an interesting twist. Since cortisone has been shown to weaken stiff ligament structures, in this particular case, that effect can actually help. Softening up tight, restrictive ligaments may allow a frozen shoulder to loosen up more quickly. Another useful scenario for cortisone is in diagnosing certain conditions. Some nerve-related pain syndromes, like the suprascapular nerve compression syndrome or radial tunnel syndrome, are notoriously hard to diagnose. They usually don't show up well on nerve tests, and the symptoms can overlap with other issues. But if we inject a small amount of cortisone into the suspected area and the pain improves, that's a strong clue that we're on the right track. We call this a diagnostic and therapeutic injection. It not only helps to confirm the diagnosis, but it may also provide relief while we figure out the best long-term plan. So am I the anti-cortisone doctor? No. Cortisone has its place, but I also know that for many conditions we now have better options. Treatments that don't just mask the pain, but actually help the body to heal. For example, in arthritis we have hyaluronic acid injections which help to lubricate and protect the joint without the harmful effects of cortisone. For tendon injuries, we have PRP, or platelet-rich plasma, and cell-based therapies which can actually stimulate healing rather than breaking tissue down. These treatments weren't widely available a few decades ago, so in the past, doctors, including me, relied heavily on cortisone. It was the go-to option, but now we know better. As doctors and patients, we need to be informed about what we're putting in our bodies. We need to think beyond short-term relief and focus on long-term health. Sometimes the quick fix isn't the best fix. When we have better options, we should use them, so choose wisely.